Let's talk about this connection then to opioids, which I think is fascinating. And I guess really the connection fundamentally comes down to the need to manage pain. Yep. And pain associated with childbirth. Maybe first question, is this an issue at all for normal vaginal delivery? I mean, do we see opioids being prescribed in that case?
Yeah, I'm sorry. So it's a great question. So the majority of physicians are not going to prescribe an opioid after a vaginal delivery unless there are other complications. So what's been interesting is there's very limited data on those rates, although a recent study that was done in Pennsylvania a couple years ago actually saw an increased rate in opioid prescriptions within 5 days of discharge from the hospital among vaginal delivery. And, to be honest, most people in the area of looking at these rates hadn't been looking at vaginal delivery because they're not often, in the majority, are not prescribed at discharge. Mm-hmm. It was this group that decided, hey, let's look at just within a week of a vaginal delivery and see. And so there was, roughly 20 to 25% of their cohort that had gotten a prescription within that first week. Now, they weren't able to track it and whether it was refilled, but it raised the alarm that even though vaginal deliveries are not, or women who are having a vaginal delivery aren't receiving a prescription at the hospital at discharge, they are sometimes following up with their doctor thereafter and asking for a prescription.
Mm-hmm. Do you know which doctor? Would that be the obstetrician again, the one who did the delivery, or a family practitioner? Or?
It could vary because often in larger practices, the physician who's on call who delivered the baby, who would potentially be on call or on service when that woman was discharged, it could be the same, and it could vary. So for a C-section delivery, usually women are in the hospital for 3 to 5 days. And so depending on whether that physician is on call all 5 of those days or not, it could vary. It could also then be the OBGYN that predominantly treats that patient, or a family practice doctor if that specialty is not available.
Yeah. So certainly not just a problem with C-section deliveries, but more of a problem there. And so maybe you can talk a little bit about what the data suggests from where you are in your work right now for those undergoing C-sections. I've learned from your project that there's no national guidelines, which is always a challenge when you don't have any standards. And so it's sort of left up to the discretion of individual providers. And we know that in that case, from the work that was done many decades ago by Dartmouth, that there's a lot of regional variation. There can be these standards that just develop with lots of variation. I imagine that's the case here. But the challenge with prescription opioids is that after a certain point in time, which is not that long, the odds of addiction get to be great. And as those increase, you worry about the long-term effects. So can you maybe talk about what you know from a numbers perspective here?
Yeah. So, there's a couple of things there. So first off, for women, so again, let's go back to the original number of about 1 in 3 women are going to have a C-section. Of those 1 in 3 women having a C-section that are then prescribed an opioid, for many of those women, it's the first time that they've had an opioid prescription. Potentially in their history, it could be one other major surgery, or it could be something like having their wisdom teeth extracted. So, that's a common procedure for many people. But if you think about exposure, that period of time after pregnancy, for all women, C-section and vaginal delivery is a very vulnerable time of exposure. And if you go back to thinking that maternity care is the number 1 reason for hospitalization in the United States, that's a lot of women who are being exposed during an extremely vulnerable time as well. So you've had a baby, you've had major surgery, and you have hormone shifts and changes. You have an increased susceptibility already for postpartum depression, anxiety, stress. And so you've combined all of those factors and then prescribed an opioid. And that opioid is going to help with the initial pain But the challenges of motherhood early on for most who've had a baby, that's a very raw period of time. And so even though that prescription may be for 5 to 7 days after discharge, it's very difficult to track the numbers in terms of percentages that will refill. Now, talking to different physicians, even though there are not a set of national standards or guidelines, most physicians across the board for surgical procedures are reducing both the length and the number of prescribed pills. So that is sort of a national push to make sure that if an opioid is prescribed, we are limiting it in scope and in length. And that is on the discussion for women after delivery. But again, that's not been standardized where ACOG or any of the other national organizations have come out and said, don't give women a prescription longer than this amount of time or this many pills. It still varies from clinician to clinician. It's very difficult to track that rate of reuse.
Yeah, I was going to ask about that. The American Society of or Association for Gynecology and Obstetrics, whether they had set some parameters, and it sounds like not, which is somewhat shocking to me, although I hope they're talking about this. I would think they should be.
They have set some guidelines and are moving towards recommendations, but there's not yet a set of arguable, definitive clinical practice guidelines that all are adhering to. So there's been a couple of policy briefs and papers coming out, which generally they will, come before the national push. I suspect that will be coming soon, but as of today, there are still no set guidelines.
So, as researchers, we often want to think about risks and probabilities. And so in this case, what is the risk of addiction and all the challenges that come with addiction, the odds of overdose, the odds of, the other negative things that come with a person who is addicted to these prescription painkillers or to heroin more generally. Do we know anything about, in this population, after how many days or so even though there's not a guideline, is it, I'll just give an example. We were talking with a pharmacy benefits manager around the example you gave, which is wisdom tooth extraction.
Sure.
And the PBM was very proud of themselves for setting a 7-day limit. But a number of us in the room said, well, how many days do you really need for wisdom teeth extraction? And the thought was 7 was too much.
Right.
So I'm curious, is it, 3 days, 5 days? Do we know where that sort of risk point increases for addiction?
Yes. Yes and no. So obviously with heroin, a one-time exposure can lead to direct addiction. Most women are going to receive some form of a pain management opioid after delivery and are, again, going to be limited in the number of pills and the length that they receive them. But in combination with the other physiological changes and the psychological changes that set the stage, the thing is, in this period of time, it is much different than just coming out of a major surgery and not having the other major changes, life changes that are going on. I don't know a rate. I have not seen that in the literature that says if a woman who has been given birth and received an opioid, after 3 days, her susceptibility increases by 50%. I'd love to see that data. I think the lack of attention to this period as a vulnerable period speaks to why we don't have those data. But I would suspect, given the increases in anxiety, depression, and stress during that time, that it also sets the stage for that susceptibility once there's wear off. So, within that 3 to 7 day window, clinically, when I've talked to colleagues and have asked that question, how much is prescribed and how much is actually needed, many would argue that an opioid prescription is needed immediately after delivery. And if a woman has had a C-section, that might be in that window of within that first 24 hours, maybe 36 to 72 hours, which theoretically is during the hospital. That should be monitored within the hospital time. It seems, though, that oftentimes, and this might be coming into play, and we hadn't spoke about this, in 2008, there was a federal rule change in terms of the amount of time that women spent in the hospital. Mm-hmm. And the idea here was to discharge as quick as possible. We used to allow women to stay in longer. Now, after a vaginal delivery, it's 24 to 48 hours, up to 72 hours for a C-section delivery. Now, 72 hours might be completely appropriate for one woman and completely inappropriate for another woman who's had a very hard delivery and has had some complications. And so often the thought is that women are being prescribed these opioids at delivery and then at discharge at a much higher rate because, in essence, without, they're sort of being kicked out of the hospital. And so the right thing to do is then send them home with some pain medicine. But if women could actually stay in the hospital a little longer, then and be monitored, in theory, they should be able to leave the hospital without needing a prescription, which would, again, when you think about policy and change, could change that.
Yeah.